Maria and Fibromyalgia by Nathan Grigg. What we know about Maria. First off, she's a 38-year-old female. She's had less than 4 hours of sleep a night for over a month. She has tenderness present above her elbows and ankles. She has a BMI of 21.6 and her blood pressure is 141/91. There's a maternal history of autoimmune disorders such as ulcerative colitis and irritable bowel disease. She has a great uncle and a cousin who committed suicide in their late 30s. She swims a mile 3 times a week for exercise, and she's a professor of sociology up for tenure in 3 months. More importantly, she has a persistent headache which causes constant low-grade pain followed by irregular episodes of exacerbating pain. Now, what we don't know is actually quite a bit. First thing I think of is how is this affecting her life? We already know she's up for tenure in 3 months. That's stressful enough as is. Now she's got pain, she's not sleeping. This can really be messing up. And with tenure being such a big deal, we want to get on track with let's get things done and let's get things moving forward. We also want to know how long this actually has affected her, because that can make a difference in the diagnosis as well. Other things such as a fever can point us in one direction, say maybe to infection or not to infection. Tenderness above the joint is one thing Maria mentioned herself, but can be kind of vague. Above the joint could be more superficial towards the skin, could be more proximal towards the body. A little clarification there would be really helpful. Skin lesions or rashes can present with a lot of diseases. Sensitivity to light. The list can go on and on. We could go on forever. But these are a couple of the most important things that I actually found. Now for a differential diagnosis, I came up with the following 5. Fibromyalgia syndrome, polymyalgia rheumatica, systemic lupus erythematosus, myofascial pain syndrome, and rheumatoid arthritis. First off, fibromyalgia syndrome. There's 3 clinical diagnostic criteria for fibromyalgia syndrome. The first one is the patient needs to have a widespread pain index of 7 or greater and symptom severity scale score of 5 or greater. Alternatively, a patient could meet a criteria of WPI of 3 to 6 and an SS scale score of 9 or greater. Essentially what we do here is we give a questionnaire to the patient with all of the pain, symptoms, things like that, and they fill out the questionnaire and it gives them a mathematical value, and we use that to diagnose fibromyalgia. Now they also need to have symptoms need to have been present for at least 3 months at a similar level, and the patient can't have any other disorder that would otherwise explain the pain. Fibromyalgia syndrome is actually an exclusion diagnosis, and so we'd have to prove everything else wrong to actually prove that they do have fibromyalgia. Now polymyalgia rheumatica is another possibility, but it's actually usually found in older patients, so it's not very likely. To confirm this, we would get an erythrocyte sedimentation rate and or a C-reactive protein, which we would actually expect to be normal. Systemic lupus erythematosus usually presents with things like a malar rash and other symptoms such as photosensitivity, discoid lupus, oral nasopharyngeal ulcers, pleuritis, pericarditis, cellular casts, persistent proteinuria, seizures, and more. A simple physical exam would help us. We'd need 4 of these or more to actually diagnose systemic lupus erythematosus, and we would expect upon physical examination to not see more than 4 of these. Myofascial pain syndrome is a syndrome where basically you just have pain in an area. And there's no clinically accepted criteria for myofascial pain syndrome like fibromyalgia, but there's a difference. The pain associated with this syndrome is typically not widespread. So it's localized more to one area, with Maria having tenderness in her elbows, her ankles, and her head with the headaches. It makes it a little bit unlikely. Rheumatoid arthritis would be highly associated with the joints. She explains her tenderness above the joint, making this diagnosis less likely but still possible. The way I interpret it is above the joint means closer to the body, more proximal, instead of more superficial on top of the joint. But if we tested for rheumatoid factor and obtained a complete blood count, we would expect them to return normal. The pathophysiology of fibromyalgia is largely unknown, but the most current research points to a strong central nervous system component. This could be due to excessive release of neurotransmitters at central nervous system junctions. So essentially the way it works is we've got peripheral and central nervous system receptors. So when a stimulus comes in, say at the knee, it gives a stimulus to the peripheral, then to the peripheral sends it to the central, which then gets interpreted by the brain. And so what happens is when the peripheral sends in, let's say, a 5, the central reads a 5 and sends a 5 to the brain. That's okay, that's normal. In fibromyalgia, what happens is the central nervous system is elevated. It's artificially releasing too much neurotransmitters. So it starts off at a 4. So if we put a 5 in at the knee, which normally would annoy a person but not hurt them, the 5 gets added to the 4 of the central nervous system, which then gets interpreted as a 9 by the brain. And that's what's happening with Maria right now. We can see a correlation with the tenderness above her elbows and her knees and her headaches, because when we touch, a normal touch that wouldn't hurt someone is actually hurting Maria. Not knowing the pathophysiology actually makes the treatment rather difficult. The first and foremost is opiates. They're the most common because we've got a pain syndrome here. There's not much data to support how much they actually help, but the first thing logically to think is pain. We need painkillers. Targeted pharmacotherapy is the most direct, but can be a little bit risky. The International Journal of Rheumatic Diseases actually suggests affecting the central nervous system's hypersensitivity, the overactive central nervous system. An example would be using gabapentin, which would act as an alpha-2 delta reducing calcium influx at sensitized nerve terminals. Basically here we've got the most direct approach, so going after the direct cause of what we think is causing the disease, but we don't actually know for sure. And so going after the direct cause of something we're not sure of could have possible side effects that could be very dangerous. Something else that is not to replace other treatments or replace drugs or anything like that is balneotherapy, because a number of drugs can be used to treat fibromyalgia, but a study by Antonio Frauli shows that balneotherapy and mud packs with mineral waters from thermal springs could serve as a safe and effective adjunct to these approaches, providing long-lasting attenuation of the major symptoms of this syndrome. There's not very much research on the balneotherapy and fibromyalgia, but balneotherapy is a safe adjunct to any course of treatment. The most important thing here is that we actually involve Maria in the treatment and decisions. Basically, it's her life and we need to figure out what's going to work best for her, because there is no one cure for fibromyalgia, one way we can even treat. The best option would be to try the safest combination of possibilities first, possibly a mild opiate with balneotherapy. We're not looking for a cure, but we do want to make her life manageable, especially with situations right now. Very high stress, tenures coming up. We want to get things under control, hopefully even get her sleeping, get things taken care of so that way she can at least function through the next couple months. We want to get things on track so she can get her life back on track. There's also a good chance we might have to reassess and change our treatment plan. That's a possibility. So we want to start things so that way we can see what's going to affect and what's going to help her most in her life. Now, what Maria needs to understand is that this is a chronic condition. It's a very sad diagnosis. It's something that no one likes to hear, but it's something that's never going to go away. And to understand that, she needs to realize that in her life, this is something that we can't cure, but we can at least hopefully manage. We're going to be working together with her to find out what helps her the most. She's going to be her biggest advocate, which comes to my third point, that strict self-management is essential to living with fibromyalgia. She's going to be in charge of her regimen. We're going to help her, we're going to figure out a plan, and we're going to work through it together. And we know she can do it. We just want to communicate to her that it is possible. Even if we have to reach out to family members, friends, to get help, that's what we're here for. We're here to go over what we can do best. The main ethical concern with fibromyalgia is the possibility for drug seeking. We have an idiopathic syndrome that causes pain. There's no way of proving the syndrome, no diagnostic test that can prove you have it or you don't have it, which makes it a prime target for drug seekers. Every time a diagnosis of fibromyalgia is made, you have to make this decision. You have to determine whether or not a patient is coming in for drugs and medication, or whether or not they're coming in because the symptoms do actually exist. The best way to handle a situation like this is to side with the patient unless proven otherwise. Red flags will always come up. You'll be able to see what's going on. You should be able to recognize some form of drug seeking if a patient is doing that. What we're here to do is give the best care we can and give what the patient needs. And so if they are drug seeking, then we'd have to take a completely different route to hopefully see what's going on and see what we can do to help that situation. But in the case of Maria and fibromyalgia, so far we haven't received any red flags or anything like that, so we'd definitely be able to move forward.